I'll be talking. I'm Dr. Silar. I'll be talking on Cathlab materials, basic Cathlab materials. So all our interventions are done through sheets, right? So one sheet, one French is equal to 0.33 mm. And one of the questions they ask you is, what is the difference between the French, the sheet in terms of French was the sheet in terms of. We'll do it parallel. Yes. So so the main thing to know is one French is equal to 0.33 mm. All right. And when we talk in terms of sheath, French refers to the internal diameter, while in terms when we're talking about the catheters and all, it's the outer diameter. That's how a 6 French catheter goes into a 6 French sheath. Otherwise, that wouldn't be possible.
Yeah, what's the color coding? He's already mentioned it there. So you have the red one, which is 4, 5 is gray, right? And the commonest ones are these. 7 is orange, 6 is green. You've already mentioned that. Yeah, go on.
And then now we have the newer sheets that have come out from Teremo. It's called a glide sheet. So basically, within a 6 French sheet, you can, with the diameter of a 6 French sheet, you can use a 7 French guide. So basically, the material it's made of sort of expands like a python swallowing something, right? So these are how it's color coded. Everyone can see here. So this is a 7 French sheet, so orange in color. So most of the, so this is what I was telling about how a guide catheter, and now how a guide catheter. So there are two types of catheters we use in our daily practice. One is a diagnostic catheter and one is a guiding catheter. So what's the difference between a diagnostic and a guiding? So a diagnostic is made of 2 layers of material, whereas a guiding has 3 layers. The extra layer is a braided, it's a stainless steel braid that is there that gives more support to the catheter. Because unlike a diagnostic catheter, our guiding catheters, we need to pass our hardware through it, right? So it needs to be more sturdier that way, right? So, so most of the guiding catheters that we get are in 100 centimeters, and in patients who are taller than 6 feet, you have to use a little longer ones, the 110, 125 centimeter guiding catheters, right? And there's something called a primary curve and a secondary curve. So each type of catheter, they come with a hub. So the hub mentions what French the catheter is, what sort of wire the catheter takes, what's the maximum size. So here it's mentioned that it's a 5 French catheter and it can take an 038 wire, right?
The whole idea is that if you are using this, the essential point is that you are using the back and the back wall of the aorta, right? And this is something that we ask in exam. Very few people know. You say it's JL 3.5. What does it mean? Anyone? When you say JL 3 or JL 3.5, what does that mean? It's written here, right? 3.5. What does that mean? Sorry? No, 3.5 means what? Anybody allowed? I have this Kanya, that guide. When you say 3.5 on this guide, supposing I show you a JL guide, and I say this is 3.5, what does that mean? It means the distance from your entry point here, right? Your primary to secondary curve is 3.5, is 35 millimeters. That's what it means. So the distance between this, if you have a JL, this to this is ridiculous. So that is what sits on the back wall of the aorta. That's what gives you support to go inside. Otherwise, it's not a great guide. In fact, I had teachers who used to teach me that JL is not a guide. JL is a diagnostic. XB is a guide. Extra backup is a guide. But this is not a great guide because it doesn't give you great support. It has to sit on the back wall. So then, if that is the logic, what does it mean? If you have a dilated aorta, what will happen? The guide will wobble. It will not touch the back wall. So you're not going to get good support up front. Sorry, go on.
So
yeah, you're good with that. Good.
So next we have diagnostic catheters. So for the radial axis, we have something called a Tiger catheter.
Right.
Although it's not called a Tiger, it's called it's an OptiTorque by Teremo company.
You should know this name,
Yeah.
correct? It's called OptiTorque. This is not, we all use TIG. It's actually Optitalk.
Right, it has one end hole and a one side hole, right? So the advantage of this catheter is without you can hook both the left system as well as the right system with the same catheter without having to do a catheter exchange, right? The same goes for a Jackie catheter. And then you have the dedicated catheters, that's Judkins left and Judkins right. Then you have your Amplatzer and Ikari, right? So with the Judkins, so what they say about the JL is unless you manipulate it, always finds its way into the left main, right? So the curve is given in such a way that it goes and hooks the left main. So these catheters have been designed with after a lot of autopsy studies and
XB.
right.
So it's got only one curve. That's why I just wanted to show.
Yeah. So this is an XB. It has a U-shaped curve, right? So the advantage with an XB is it's an extra backup. So what it does is it takes the support of the posterior of the lateral wall of the aorta as well as the cusp. So when you're passing your hardware, you have support of two structures. Unlike where in a JL, it just takes the support of the opposite wall. It doesn't actually go and sit in the cusp, right? So this is the JR catheters. So you can see here in the so here as you go from JL to an Amplatz left, you can see that the guide support keeps increasing, right? So these guides give you're taking it's called more of an active support than a passive support. And this is your right catheters, your Judkins right, Amplatzer right, your MP catheters, right? So,
the most common used is JR.
JR.
In anomalous positions, we may need to use other ones. What he's showing you is a JR catheter here. So this is the most common one, and it's used also for other entry into other structures, particularly renals, or if you want to do a subclavian shoot, you can use a JR. I mean a JR diagnostic. This is a guide, of course.
So this is what we are meaning in terms of supports. You can see here, see the JR doesn't take support of any structure there. It's just going and sitting in there. So when there's a tough lesion, you try to push and pull your hardware, there's a high chance that your guide's going to back out. But if you see the AL1 here, right, it takes support from the posterior wall and it takes support as the coronary cusp as well. So you have more support when you're passing in hardware through difficult lesions.
In anomalous structures, in anomalous RCA entry, particularly the second one, you see that. Okay, you could use something like an Amplatz catheter. This is an Amplatz in his hand.
Yeah.
Amplatz is there in there?
No, the previous one is.
Oh, the previous one, sorry.
Yeah.
Which one is that?
That's
That one.
for the right.
So
yeah.
that's the Amplatz in your hand. So you see, it has a curve which is a lot more sturdier, but it's also known to damage the structure a little more. So you should be careful with the ostium. You should be a little careful. Amplatz left is available. A little looking down, Amplatz right is also available. AR.
So as sir was saying, the JR catheter we even used to hook the grafts to take Lima shots. It's basically like a multi-purpose catheter because the curve is not so acute or so obtuse that we can use it for most
entry into peripherals, entry into the leg across iliacs. That can also be done with a JR catheter.
So this is something called a guideliner. So a guideliner is basically an extension of your guide, right? So if you're not able to track something or deliver something to right, suppose you have a lesion in the mid LAD, you're not able to track it through the prox LAD because of any calcium or whatever. So you can use a guideliner. So a guideliner you have a 25 centimeter of rapid exchange, right? So through which you can take in your stent or your balloon, whatever it is. But the one thing you need to be careful is this tip may dissect your proximal structures. So that's one thing you should be careful of when you're doing that. So
next year. Cool.
So
balloons, you're there. You're on balloons.
These are the microcatheters.
Microcatheters.
Yes. So for microcatheters, when you crossed a CTO, you want to take on a microcatheter, make sure you're in the lumen. So you have different types of microcatheters.
It's a 2.6 French thing that goes inside the guide.
So this is a microcatheter. The one we use here is a fine cross, right? There are other specialty microcatheters also like a Tornus or a Turnpike, wherein the specialty ones to use during CTOs.
The whole point of keeping this talk and the next one, though we knew it was more intervention, was two years back, there was a mess in the paper. Scoring balloon was asked, cutting balloon was asked, things which were not really in syllabus were asked. I don't think any of them were prepared for it. So we don't know up to what extent they want your real curriculum. In the previous talk, DORB was spoken about. DORB is not a part of your syllabus. I don't know what MSc, but at least BSc it's not. So that's why we're trying to cover whatever we can.
And there are some catheters like a dual lumen catheter, where so when your wire is in one way and you want to enter an acute side branch, there's a 180-degree opposite. There's an exit hole for that. So you have the Sasuke and the twin pass. So guide wire. So guide wire basically is made up of three structures. You have the tip, you have the coating, you have the core. So a tip, you might have heard something called a tip weight, or like whenever your primary operator asks for like a Gaia or something, they ask what's the tip weight, right? So what do you mean by tip weight? So when you take a catheter, so when you take a wire like this and you push it like that, so the amount of the distal 1 centimeter, how much it bends. So the amount of force it takes to bend that is determines the tip weight.
XYO. Outside the body, he's saying. We need to bend and see at what point it bends. That's what they say. You say like 1.5 grams or 3 grams or whatever that is. It's
So
called as a tip load. Yeah, sorry.
that's the tip load. And then you have catheters that the guide wires that taper in, right? Like your Fielder XTs and all, which have a tapering tip. And then the coating on the wire. So you have two types of wires, which are hydrophilic and non-hydrophilic. So the workhorse wires that we use commonly, like a BMW or a run through, they're non-hydrophilic wires. But hydrophilic wires are usually more specialty wires, like a CTO wire, where you have a Gaia or a
At
Miracle,
least
or
these names you should
yeah.
know. At least if somebody asks you the names, and you should know the names, they'll ask you always, what is your institute using? So at least they know the names of those. It's okay, we can go to the next one.
Yeah.
Next one, just go.
And then coming to balloons,
Balloons, they'll always ask you, get some balloons on.
So you have two types of balloons: the standard balloons we use to prepare the lesions, compliant, non-compliant, and then you have specialty balloons for plaque modification. So what do you mean by a compliant and non-compliant balloon? What is the difference is, in a non-compliant balloon, the more pressure you go on the balloon, it starts to dog bone. Like you can see here, the balloon below. The higher you go up, it doesn't open the lesion, it expands longitudinally. Whereas in a non-compliant balloon, the force is exerted more radially. So, it doesn't deform longitudinally. So this dog boning doesn't happen there.
That's why dissections are lesser. Otherwise, you'll end up dissecting more with a compliant balloon. Non-compliant is generally used when you're already stented and you want to now expand the stent.
So this is important for this thing. And the other thing is, whenever you hand over balloons, you usually tell what is the nominal pressure. So that is the pressure at which the balloon expands to that diameter what the company specifies. And there's something that's there below after 2, 3 more atmospheres, what's called an RBP, which comes encircled. So it's called a rated burst pressure. So it's that pressure at which 99.9% of the balloon will not rupture. So for most, it is like about 20. So beyond 20, you have a high chance that your balloon is going to rupture there, right? And then there are the other specialty balloons that you have, which you
This
have
is something you should know now going for your exams. Okay, for those who are in CCT, sorry. Yeah, go.
So you have the Scoreflex, the Angiosculpt, the chocolate balloons. So what these balloons basically have is, so an Angiosculpt basically, it has three nitinol wires that are intertwined. So when you expand the balloon, you're sort of giving a cutting effect to the lesion, right? It cuts open and dissects the lesion in a more controlled manner. Especially in fibrotic lesions where you see the balloons keep slipping, this sort of holds on to the lesion and in a controlled fashion dissects it. Then you have cutting balloons, which have atherotomes. Atherotomes, you can think about it as like, sharp blades that are there, and which sort of, dissect the lesion in a controlled manner. The only thing,
Particularly used for like heavily calcific lesions, these two materials.
and now the newer thing, what has come is the drug coated balloons. So you might have heard of the mosaic balloon that's being used commonly, right? So these are balloons that are coated with a drug that was typically used on a stent to prevent neointimal proliferation, right? This balloon you only use after you've properly prepared the lesion. You don't just go ahead with an 80% and just deploy this balloon. You first prepare the balloon and then prepare the lesion, and then there's something called an OP and NC balloon. So the OP and NC balloon, you can go up to, as I told you, the rated burst pressure for most balloons is about 20, right? So with this, you can go up to even 34, 38 atmospheres. So the thing with this is it has two layers of material in it. So the balloon has two layers of material, which gives you that sort of expandability that you can go up to such high atmospheres. right?
This could be asked because again, this is used in like current practice for calcific lesions. This is like giving an ultrasound into the heart. You just pulse the heart calcium by giving more pulses. Uh, it's called intravascular to the job. I'm sure you've all seen it in your hospitals.
So basically, you deliver it's like basically what they used to use for kidney stones. You
Kidney.
basically break in the calcium, right? And then this is a rota ablator. Most of you would have seen this in your labs. So basically, it's nothing but like to say it in terms of it's a drill. You basically drill in the lesion, prepare the calcium. So it has it comes on its own wire. It's called a rota wire. It's an 0.09-inch wire. Unlike the conventional wire, it goes on that. There are two varieties again, and the standard and the stiff wire, depending on the lesion. And the thing with this is it has the hub has the diamond. This is basically diamond coated, like it has diamond bits in it. So it's only there on the distal end and not on the proximal end. So sometimes what happens is when you go too aggressively, it gets stuck there. Unlike rotational atherectomy, which you can use for both forward and this thing, this
Orbital
huh?
orbital
Or the orbital atherectomy.
This is called as a rotablation. There's something called orbital atherectomy where you can use it both front and back as you burr. Burring. I mean the term is burring. Burring. It's like drilling. The word is burr.
And then coming to an IABP machine. So this is the most commonly used form of mechanical circulatory support. Uh, so basically, it's a balloon that's kept at the just distal to the left subclavian artery, and it basically expands and deflates. So when does it expand? It expands in diastole. So why does it expand in diastole? Because the filling of the heart, the blood vessels of the heart fill in diastole. So when it expands in diastole, you're pushing in more blood through into your coronaries, and when it deflates, what's happening is creating a suction effect. So it sort of decreases the afterload by 15% as well, right? It becomes easier sort of for it relieves some pressure off the LV in that sense. So this is what you would want to see on your whenever you put on your IABP. This is the unassisted systole. This is the patient's own systole. So it's usually timed to the ECG. So at the peak of the R wave is when the balloon inflates, right? And this is your diastolic augmentation. So you can see that it has augmented it more than the regular what it would have been.
The first beat is your normal pulse, which is not using the IBP. The second one is what is the IBP, where it has gone up in the diastole.
And then next coming to stents. So stents have come a long ways. The initial stents that were there were all 150 microns in diameter. The current generation stents from the Indian stents are about 69 microns as well. The Zions and all these are 81 microns, right? And then there are so stents come with sort of the differentiated into polymer coated and biodegradable this thing. So basically the polymer sometimes can cause some inflammation and cause restenosis, and so some companies have come up with the biodegradable stent wherein the polymer itself dissolves, like the Osiro, the Synergy stents, the biopolymer coating goes over time.
Put as simple as this, a primer is what is used on the paint. That primer is the polymer, and that remains. Even if the stent is there, if you had something which dissolves, like called as a biodegradable, it wouldn't remain. So most of the problems in stents have been linked to this polymer, which remains inside the heart. So as he said, biodegradable means it stays there, and then after 6 months, it'll vanish. Only the stent remains. There's nothing between the stent and the vessel wall. So they have been seen to be less traumatic and less inflammatory in the longer sense. Are you done?
Yes.
Great. I'll just take over from here. Very, very basic about some interventions that you need to know. And I mean, I promise I'll finish this in 10 minutes, 10 to 15 minutes. This is basically called as the nuts and bolts of intervention. Uh, all of what we spoke, this was a talk that was deliberately kept towards the end because all of what we spoke is going to be sort of integrated here. When you when we start some kind of a procedure, we always take your echo to the Cathlab, and the plan is made there. For example, a simple thing like a balloon atrial valvotomy, I would see whether the valve is unicuspid or bicuspid, because the balloon valvotomy works only in a bicuspid valve. So the point is that you need to plan for war, not going into the war. The plan is made before the war. So I think I'll go with this, right? So in any case, see what you need to know for your advanced CCT paper 3 is this, right? I wouldn't mind if all of you sit this side. Like, is it visible from there? Okay. So, you should know at least the steps of PTMC. This is what, I have been a paper setter, madam has been a paper setter. So this is what we essentially put, that at least bare minimum what you should know. Some of which it was covered also by Silar. So you should know about the coronary wires, you should know about the peripheral wires, you should know about the balloons, you should know about stents, you should know about some part of congenital cardiology, right? And you should also know the device closure. Not everything could be covered in whatever 8 or 9 hours of today, because that is one topic we couldn't cover too much. Dr. Vijay Sai like just touched upon it, but it's a whole new subject by itself, and some of which you should know at least by the names is something like instant restenosis or dissections in the coronaries. Probably more for MSc, but also to be known at the BSc level. So at a very basic level, what is PTMC? You already heard about it. I mean about rheumatic MS from Arun, but then when you do an echo, what you should minimum know is this: how are the commissures? Is it really commissural, or is it more subval? As text, you should see all this, because if it is commissural, it's going to help by doing a BMV. What's the point? If your commissures are open, what's the point of putting a balloon in and trying to open something which is not really closed? So if it is subcost, if it is subvalvular. So the point is that. Second thing is, when you do a PTMC, are you safe? Never do a procedure. See, all this is your responsibility as techs. Is there at least when you are seeing it, is there a thrombus? It might form later. It might form in the next 1 week when you are waiting for the PTMC. But when you are seeing it, number one is, are you going to be making it safe? So if you have a bulge, too much bulge of interatrial septum, the puncture becomes difficult. That's one. The second thing is, can you use something beyond a 2D? People have tried TE, that is more for clots, etc., and IAS bulge. Can you use a 3D? There is a score for it called as an Unver score. Never been tested in Indian populations. Uh, it's okay. It's there. You can just read about it. It's called as the Unver score. There's something called as Sutaria score. Sutaria score is more for mitral regurgitation. The other scores which we use here, the commonest one is Wilkins. So you must know Wilkins, right? And you must know all the entire table of Wilkins. And the way Wilkins described this, always in your life, write it as MSTC. Always in that order, because that's the way it was described. The mobility, the subvalve, thickness, and then the calcium. Because calcium is one thing which is going to lead your valve to rupture or to a commissural tear if it is too much. So this is the steps. I mean, I'd actually made it for those who would not have seen it. If you've all seen it, great. But you see the bulge of the septum there, the step-by-step PTMC where we go across into the SVC, come down, we see the bulge, and then we puncture it, create a small hole, create a bigger hole with a dilator, then put the balloon inside. So this is a tenting of the septum. You could be shown these. Some of these were actually from exams from Jaydeva, from other hospitals where we have managed to pick up the pictures. This was kept as a spotter. What is this? This is actually the tenting of the septum when you put in uh, uh, the broken bro needle. And then, of course, some of these traces were shown where you have uh, an LA to LV gradient. There, this is the gradient of mitral stenosis, where you have a simultaneous LA-LV gradient. The LA coming from the balloon in the LA, the LV coming from the pigtail in the LV. So LV EDP there. So that is the thing which sort of gets relieved when when the valve is open. So these things can be spotters for you. There's something this I've written on the top called as impasse sign. Impasse is when you put in a balloon. This was also asked. This was actually asked in one of the CCT courses in Maharashtra. In Bombay, this was asked. Impasse sign is basically when, if you're opening a balloon of like balloon mitral valvotomy, always the distal balloon opens up first and then the proximal balloon. But if the distal balloon is caught into subvalve apparatus, then your proximal starts to open. This is called as the impasse sign, and it might tear the valve actually. This was already discussed by Arun. That is the LA thrombus classification. They love asking it in our institutes here because Jaydeva generally sets the paper and they have this, so they'll always put this classification. And he had already covered this. You need to know this. This is an indigenous thing. The other thing is which he mentioned also was Dr. Vijay Lakshmi ma'am's score, which was mentioned about the acute valvulitis. You must know this. These are 2 or 3 homegrown scores which you should know. The bye. Thanks, Arun. Thank you so much. Thank you, sir. Thank you so much. The balloon that is generally used for valvotomy is the Inui balloon. Kanzu Inui was actually a surgeon. A surgeon taught us to do valvotomy. You should know this. Acura balloon is something that we all use in our institutes. We use it. Jaydeva does. Acura is a balloon not for mitral valvotomy. It is a balloon for pulmonary valvotomy, but we are using it for our purposes. Jomiva is a balloon from CMC Vellore. In case some of you are from other states, Jomiva is basically Joseph mitral valvotomy balloon by George Joseph Sir, who is also the unit head there and the head of peripheral interventions. It's Jomiva, in case you are asked. It's a different balloon altogether. Earlier we used to be, when we were residents, we used to be shown these kind of pictures. This is actually also taken from one of the DNB exams. This is a blade commissurotomy. We use balloon, so you can use a blade to cut across. It's called as a blade commissurotomy. It's actually like a hexagon which cuts into the valve. This is the Jomiva balloon, okay, which George Joseph Sir has actually sort of designed from CMC Vellore. This is a trace also that might be shown to you. Of course, I don't know whether traces are shown, but I mean, definitely for MSc, it's important. This is a trace where you can see that post PTMC, there's been a severe, the V wave has gone up completely. So that's the severe MR, basically, which is seen, which is not there pre. Catheterization will be asked to you to a certain extent, right? For the congenital heart disease, it might be asked to you. And important terms that you will be asked, one is step up. Step up is always asked in your exams. So what is significant step up? If you go from RA, RV to the great arteries, it's basically 11, 10, 5, 8. So anything which is a step up, more oximetry step up of 11 in the atrium, 10 in the ventricle, 5 in the great vessel, and atrium to great vessel, 8. So 11, 10, 5, 8, that is called as significant step up. You will be asked this. Some of these terms were actually mentioned by Vijay Sai sir also, how to calculate a shunt on echo. This is the graveyard, absolute graveyard of exams, but you should know this because this is the whole of cardiology in one picture. The entire cardiology in one picture is this picture, and that is the Vigor's cycle. If you understand this, you understand anything in echo, anything in intervention, anything in cath. And if you do not understand this, you will be wobbling all through your life. Sit with this picture, draw it, understand it, correlate every trace to PQRST. Then you are good. Otherwise, you're not. You don't need to take pictures of this because this is there in every book. Every cardiology book starts with Vigor's cycle. It's called as the cardiologist cycle or the physiologist cycle. At what time what happens? This entire thing is about that. At what time you have systole, at what time you have QRS, at what time you have diastole, and as per that the pressures will go. So I keep asking in the lab, what is QRS, where do you take LVEDP? Basically all of that is this. It has to, you have to take a line from the QRS, cut and see where the LV trace cuts. That's your LV and diastolic pressure. Normal findings, they always ask you this. What are the, I think a couple of years back, there were 8 questions on congenital, 8 or 2, 3 or 4 years back in the midst of COVID. People were harangued with that kind of, paper 2 or paper 3, I think. So everything was 7 or 8 questions were on congenital. So you should know at least the normal values, the normal findings of the chambers, normal oxygen saturations. The most deoxygenated is the coronary sinus because that's the vein of the heart that gets the blood. After everything is taken up. So the most deoxygenated part is the coronary sinus. And anywhere if you have SVC more than 70 or 75, you should think about a shunt. You will never get an SVC or an RA more than 75 unless there is a shunt. I always tell this to our residents, and you should know this as techs. If you're doing an MSc in a Cathlab course, plan your course for a cath. You can never do a cath of a child a second time. Your echo is paramount. If your echo is wrong, everything goes wrong. So see your connections well before you go in. Don't take an IVC, go there and say, oh, this is an IVC interruption. That's stupid. Okay, you should have picked it up before it happened. Then, of course, some of it was already discussed by Silar. Arteriography, this has all been discussed. Some of those catheters are important, particularly the pigtail. They'll be asked to you. Spotters are shown. The right heart cath is simple. It has 2 parts, oximetry and angiography. Oximetry is taking oxygen from all of the chambers and the great vessels. You must finish this in 7 minutes. Because in 12th standard, we learned something called as a steady state oxygen consumption. The SSO2 happens only for 7 minutes for all of us. After that, the oxygen consumption will change. So go to the SVC, come down quickly RA, come down to RV, come down to IVC, go back to RA, take pressures, go to RV, go to PA. This whole thing should get done in 7 minutes. If you see the blood flow calculation, it can be done in terms of cardiac output. It can be done by 2 things, by both the thermodilation and the fix. This is again a little difficult to understand, but then this is the backbone of cath that we see for oximetry. Everything in again 7 minutes. I already mentioned this, and always take the post-oxygenation cath if you're doing a study for oxygen oxygen, like after saturation for the operability particularly. You don't get to see the classical Swan-Ganz and all now. You use like general catheters, which we use are a common 5 or 6 inch catheters. But cath has come a long way. Nobody uses two big catheters these days. Nobody uses glass syringes anymore. You would never have seen this. We had seen this in our training time, but nobody uses this. And don't, the one thing that I want to tell all of you as techs is, don't wait after taking your oxygen sample. Right? After you take those 6 or 7 samples, don't say, I will take post-cath and then take it together. Don't do that. It doesn't make sense. You have to immediately go with that, because ABG decides everything. That decides life and death for a child, particularly those who are doing for our oxygen study for operability. This is the normal oxygen saturation and the pressure. I think we'll share this also along with you after we make, after we are done. This is what I was saying. 5775, if you're taking multiple samples, but most of our institutes don't take multiple samples. So 7557 is what you take at the atrial level, at the ventricular, if you take multiple samples. But all of us take single samples. So for us, it is this one. So at atrial level, when you come from SVC to RA, anything more than 11 is called step up. Anything more than from atrium to ventricle of more than 10 is called step up. You have done an oximetry, and then 5 is something at the great vessel level, and at 8, at any level, if you get a more than 8. So this is very, very important to know. If institutes do not have too much of congenital, at least you should know this much, what is called as an important shunt by oximetry. That means if there is an AHD, right, my SVC, if it was 65, it should become 76. Right? Because I'm saturating at the RA level. So if my SVC2 at the atrial level, there was a step up of at least to 76, that means my ASD is good enough. Similarly, if my RA was 65 and I'm thinking of a VSD, my ventricle should become at least 75. That's called as a significant shunt. Similarly, if there's a PDA, my ventricle was normally 70. It became 80. That means it was more than 5. So again, it is significant. So this is the most important thing that you should take. And there is no congenital cath without knowing all of this. Step up and step down doesn't happen really, but step up is more important. At various levels, you will be asked this step up. At atrial level, most common ASD, or a PAPVC, or a rupture sinus of Valsalva to the RA or whatever. VSD most common at the ventricular level, and PDA can happen if there is a PR. Similarly, at the great arterial level, PDA is the most common, correct? Because you're going RV to PA. So at PA, what would saturate? Something from aorta to PA. That is a PDA or an AP window. So these things are asked. Uh, you should understand that you're going into an era of structurals. So this becomes very, very important at this level, particularly for going into a case and going off a case. That means if a patient has undergone a surgery and now you have a post-op referral asking for you, is there some kind of turbulence happening? Now, if you see that, you should alert your surgeon, you should alert your team. Is there a residual PDA? Is there a residual VSD? Then we take it up for a cath. It comes back to us in cardiology. So the surgeon will say, is it significant? Tell me. So then we go back and check and say, yes, your PDA is still residual. I might have to put a like a device, or you might have to go down and then revise your VSD. It does happen. You put a patch. 4th or 5th day, there is a blowing murmur. The patch has come off. It happens. It's not about an institute or anybody's technique. Because how the body accepts the patch, nobody knows. The patch could get dehisced. So it's important to know all of this for that level. Coronary angioplasty is, I keep saying this in the lab 100 times, it's not access via balloon stent. It's not. It's a lot more, because it's all about hemodynamics. Whatever I spoke till now should get carried forward. But the basic steps are these, that you take an axis, which was already discussed by Silar, 4, 5, 6, 7 French or whatever. The Frenches are getting larger because you're going for large bore axis, for TAVR, for this, for that. So those are getting larger, right? And the most important steps is to plan the device. It's not important for you to do all this, but you should know what access is available. At least in your exams, you should know it's radial or femoral. And the plan is made for us even before that. Am I going to do a double bifurcation? Am I going to put 2 wires? Am I going to put 2 balloons? I start with the femoral. So it's like that. The plan is made not in the lab. The plan is made off the lab. And we already discussed about catheter wire balloon. POBA is something which is again asked in exams, plain old balloon angioplasty. Okay, that means you don't do a stent, you do only a balloon and you come out, and that's how it started. The first POBA, what I've written here, it was done in 1976 by Andreas Grutzing. And the patient lasted longer than the doctor himself did. because they had not put stents at that time. So the point is that, so you can come off with POBA in smaller vessels. This is an alert like checklist. So if you are going into a cath, you should know at least this much. And this is more for the MSc guys, but then also for your basic guys, you should know when you start, because you are also guiding the intervention. Is there tortuosity? Are there groin issues? Sometimes in the middle of a case, you just have hypotension. Why? It could just be a bladder. That's all. Nothing else. You have a patient who has not passed urine for 4 hours, and it's just bladder causing it. And then you are searching for bleed and HB drop and groin hematoma. Nothing is there. So that's how things pan out. So there are a lot of things that happen in the lab for which you have to be prepared. Calcium is something that you should see in the coronary. Correct. So you are prepared, as you said, with your rotablator or XYZ, whatever, cutting balloon, etc. And a lot of this is learned on the job. I'm not saying everything is here. I'm going to skip this because you already spoken about the guide wire and the core. All that was discussed. There is a bit of overlap between our talks because we thought we'd make it into 2 talks. I'll skip all of this because this is about CTO wires, the guide wires, the guide catheters, catheter sizes, which we've already discussed. We are in an era of vascular closure devices now, where we use we no more just hold the groin, right? We go for vascular closure devices, so that's important. For different kinds of takeoff, we have to take different catheters, as was mentioned by him also. A regular thing is only done with a JR, but if something like this is there, right? That, see, you have a takeoff which is on the extreme left here. You have a takeoff of the RCA which is called as a shepherd crook takeoff. It is oblique up. So you can't put your JR there and do your procedure because the JR will keep flopping. You have to take a catheter which sits like this. That's why we have shown you a Amplatz catheter. That goes and sits right into that. It gives you tremendous amount of backup support, though it comes at the cost of dissection. You have to be careful about these, but these are only things which are used when they are needed to. So this is your jail catheter, what he was mentioning. Unless you fiddle around with the catheter is designed to go and sit into the jail. You really don't have to manipulate it. That's how it uses the back wall. I was asking you about the JL 3.5 and all that. So it's basically this. It's this to this. That's what's important. Because if this doesn't touch the wall, it will start wobbling. So when you see a large patient, and this is for my techs and all techs, see the patient and then take your JL and this thing out. Okay, it's not blind. You don't take a catheter out just because the patient is on the table. See the patient. If he's tall enough, obviously his aorta is going to be wide. So you start off with a 3.5 or a 4. Don't take a JL3 and then start wobbling around there. It doesn't work like that. Then you are forced to use a second wire. You're forced to use, all that guideliner business and all. It's not required. If you see a tall patient, start with a 3.5 or 4 because his this thing is going to be wide. Selection support was also discussed. So as I said here, you can see how nicely that Amplatz sits into it. You have a jail that bobs, but you see this, if this sits up here, this would like it would go and actually hook into the ostium. EBU is a much stronger guide, as was mentioned again by him, than a JL by itself is. This is your shepherd crook deformity. It's these things where they have been asked sometimes here and there. If you are doing really well, you really need to know all this. Otherwise, no. It's okay if you want to just pass your exams. We are not here to teach you to pass exams. All of you will pass exams. Uh, this is not required again. Jackie was spoken by him. Arterial grafts are generally not asked for you guys. One thing I wanted to do was about the congenital part. I have promised you that I'll finish in 10 minutes. I've already gone beyond 10. So this is something you will not see so much in your practice. In your hospital, you may not be able to see. Pulmonary valve stenosis is dilated with a balloon, right? The balloon can go more than the annulus size. You should know this. You can go up to 140%. And it is just a simple procedure of passing it. I think there is, this is how we decide. This was also spoken by Dr. Vijay Sai. We see whether the valve domes. If the valve domes well, if there is a post-stenotic dilatation, that valve is good for a balloon mitral valvotomy. If it is not dilated, that means it's not a great valve, it's a dysplastic valve, which you generally see in echo. This is how the steps are. You would basically just actually pass a wire and then you would crack that valve open. You can see that there is a waste in that valve here down here, which gets opened up as the valve. You can use a single balloon or you can actually use a double balloon also. This has also been used in the past, not very commonly though. So this is a standard procedure. You have a wire that goes around. You have a balloon that is passed. the balloon gives you the waste right in the center. You can see that, and then it gets cracked. This is from one of our cases where you have we have used a balloon to actually good effect to open the valve. If you have a large annulus, then we can actually use an Acura balloon, which it is actually meant for. Like which I told you is like it's being used for PTMC. It's actually a balloon for this procedure. Sometimes you can take a jugular access. That's also been described. If you cannot go from the leg, you don't need to for suicide right ventricle. It's okay. This is all for much advanced level. Also, aortic valve balloon dilatation can be done in the same way, but generally you don't do it with a larger balloon because your aortic valve will tear. It's used as a bridge in adults as well till you get to your tower or during tower as well. You would cross the valve retrogradely, that is from the leg. You would put a wire across from the aorta into the LV, and then you would take the balloon to open up the valve. It's a straightforward procedure that they might ask you about, are we pacing during the procedure? Because you don't want the heart to move too much. That's all. What else is important here? This is the typical steps in a BAV. The first, sorry, it's not playing. Yeah. So the first step is to define that. Number one, you have seen the doming valve there, right? Then you pass the wire across it. This is the retrograde wire, it has gone, and you just open up with a balloon, and then you take an aortic shot again to rule out any aortic regurgitation. This is not a procedure that you would see commonly. This is known as alcohol septal ablation, is used for HOCM. 2-3 years back, there was a question about this. In 20 or 21 in CCT, this was, I mean, we had an indication of PTSMA or something. Again, that was out of syllabus, but they have started putting these questions. So alcohol septal ablation is basically done for HOCM. We pass a wire in the septal, right? And we give an alcohol there and we chemically necrose it. This is the only procedure intuitively in cardiology which kills muscle. So you want it, otherwise you keep doing primaries. This is the only one where you intentionally damage the valve, I mean the septal, and that causes the gradient to reduce. Device closures have not been seen very clearly in talks today by either of our speakers because they were more on echo. But then they were mentioning this. So I was mentioning this initially that if the shunt is more than 2.2, it needs to be done. A very straightforward procedure. That is AHD closure. Who needs it? A shunt of more than 1.5 is to 1. So what I need to show you is just like this. You have got these basic steps in which you do a T, of course, or a TT. You define the size. You cross this right from the RA to LA, and you park your wire there, and you come down and you pass a device. It's a very straightforward procedure. This is how the procedure is. You go from the IVC to the RA, right, and then open up the first disc, and then you just pull back and deploy the second. The problem comes because these rims get floppy. They get floppy, your sizing may not be correct, which is why TE plays a very big role. 3D plays a very big role today. These are all names of devices. You don't need to know all of this. This is the, sorry. So is this playing? No, it's not. If there's an interruption in the leg, how would you do? You can actually do a AHD device from the neck. We have done this double AHD device. You can put two AHD devices with the same route. So these have been done. You can do multiple devices with what is called as a cribriform device. At least know the names of these procedures, of these devices. It's called a cribriform device. VHD can also be done. This is a VHD. This was also shown by Sir. So you would typically see if the LV is dilated. That is your indication. LV dilated means your shunt is good. What you should know is this picture that you should draw in your exams. Okay, because this shows all of it in one slide. It shows you that there's an inlet extension. This is a mid-muscular VHD. This is an apical VHD. You should know in the PSACs what comes at 10, what comes at 2. So that if you are outwards here, outlet, so it will be like an outlet VHD, a subpulmonic VHD. While this is an inlet extension, or this is a perimembranous. So you can have all of these in various sizes and shapes. But generally, the perimembranous are the ones that are more suited for device closures. So this is, you have a VHD device closure here, in which the first step is actually defining the VHD. So we have an LV angio there. It shows the VHD. Then we have passed, it's an antegrade approach. We have actually passed the device there, almost no shunt, and then release the device, and then you can go antigrade and you can go retrograde. Antigrade is when you go RV to LV and do the device. When you come from retrograde, you make an AV loop and you can actually put a device. So you have a VSD here, right? And then we have created an AV loop. That means we have crossed retrogradely. We have crossed from the aorta. The wire is in the LV, comes across the VSD to the RV, PA, snared, pulled out, and then we have deployed a device. This is called as an AV loop method. That is a retrograde method. PDA coils, sir was also mentioning, coils are up to 3 millimeters. Devices are generally more than 3 millimeters. And larger, we use a device. And these are called as piccolo devices. Some of these are actually used in infants even less than 1.5 grams. So the first step is to define the PDA, right? You would see the PDA either in the lateral aortogram or in the RAO. And you can size this here. And once that is done, you would cross it. And this is like a very straightforward procedure. You would cross antegradely, take the wire into the aorta, that is IVC, RARV, PDA down here, creates a hairpin loop. This is also asked in exams. A hairpin loop, they'll show you and say, like, what procedure is this? And then straightforward deployment of a device. COE is the last thing I'll discuss because coarctation is something which is very commonly seen in children, leads to LVH, leads to an outflow tract obstruction. The first step is to define the coarctation. You can see it's very tight here, and we have crossed it, then short it, and that is then you would pass a stiff wire across it, and that is then stented, or it is ballooned. If the child is yet to grow and not reached its complete size, you would just balloon it. But if it has reached the complete size, 12 years or over, then you need to stent it. 12, 14 years, you can stent it and then redilate it. So we had a stent which was again dilated. I think it is the end of the talk. Thank you so much. Thank you for staying back here. Thank you for staying back here. See, this is a very, very long talk, right? Some of which we could not entertain today. We'll probably put up in your group, and we should be done with any questions which you can share with us later. Thank you so much.
We need just 10 minutes of yours. Are you missing your train? Very good. Thank you. Very kind of, really kind of you. So we're ending now. Thank you all for staying back. It was very, very kind of all of you. And morning, actually, there was a bit of a mistake in a way. In a way. Uh, Somebody said standing ovation and all that. That should be given now. And standing ovation for all of you who stayed back. So I think we need to stand and say thank you to all of you for having stayed back, for having attended, for having learned, for having participated. And this vote of thanks, they told me that we're supposed to give vote. Sit down. This vote of thanks is actually, I think the real work of this whole conference has been done. Of course, we got the inspiration from Swami, and we need to thank him from beginning to end for this event and for every event. But the real hard work has been done by a few people in this hall. We'll start with our CCT girls. We have only girls, so I say girls, but the entire CCT program has been made by them. The brochure, the emails, the collecting your responses, the responding to your responses, making the groups, making the Google forms, everything A to Z was done by the girls. And we can't thank them enough. This program is by them, for them, and by them for all of us, for all of you. Yes. Every one of them, right from first year to third year, to the interns, to the staff, they were completely, whatever Sir said that 1 month we've had sleepless nights was not mine at all. It was these girls working overnight, over beyond their hours. Then Dr. Prayaag, who made several PPTs, modified, changed, helped in so many silent ways, which I cannot describe. And I have Praveen sitting right at the back. And thank you so very much, Praveen, brother, because the consistent and unconditional help which he gave and support which he gave to all the students, including all the, there's endless amount of IT work which has gone into this, silently doing everything, taking care of all the logistics and everything. So really cannot thank enough, I would say. Thank you, Praveen. Thank you to all the girls. Thank you, Divakar brother. And of course, our students who served as in-house faculty, Dr. Barua, and morning we had Dr. Rajesh Shenoy, Satish Govind sir, and Dr. Arun, Dr. Vijay Sai sir, who were there. Dr. Sunil Bora, he's an echocardiographer as much, and I think every one of them played their role. There's also to thank the AV team. Kumaresh is here, and the canteen, the housekeeping, everybody. But I think the whole credit, right from Swami's inspiration to the final execution, was done by our senior managers and the girls. And Prayag has played a very big role. Thank you very much. We will just have a little aarti if you can stay back for another 3 minutes. Thank you. Oh no, it had fallen. साई हरे भक्त जना संरक्षक भक्त जना संरक्षक पति महेश्वरा ओम जय जगदीश हरे शशिवदना श्रीकरा सर्वा प्राणपते स्वामी सर्वा प्राणपते आश्रित कल्पलतिका आश्रित कल्पलतिका आपद बांधवा ओम जय जगदीश हरे माता पिता गुरुदैवमु मरियन्तयु नीवे स्वामी मरियन्तयु नीवे नाद ब्रह्म जगन्नाथा नाद ब्रह्म जगन्नाथा नागेन्द्र शयना ओम जय जगदीश हरे ओंकार रूपा ओजस्वी ओ साई महादेवा सत्य साई महादेवा मंगल आरती अंदुको मंगल आरती अंदुको मंदर गिरिधारी ओम जय जगदीश हरे नारायण नारायण ओम सत्य नारायण 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 ओम नारायण नारायण ओम सत्य नारायण नारायण ओम सत्य नारायण नारायण ओम जय सद्गुरुदेवा नारायण नारायण ओम सत्य नारायण 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 ओम नारायण नारायण ओम सत्य नारायण नारायण ओम सत्य नारायण नारायण ओम जय सद्गुरुदेवा नारायण नारायण ओम सत्य नारायण 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 ओम नारायण नारायण ओम सत्य नारायण नारायण ओम सत्य नारायण नारायण ओम जय सद्गुरुदेवा ओम शांति 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 समस्त लोका सुखिनो भवन्तु समस्त लोका सुखिनो भवन्तु
समस्तलोका सुखिनो भवन्तु। ॐ शान्ति शान्ति शान्तिः। जय